Gosh, thank you so much. I don't know if I've ever had such an introduction. It's very kind. One of the first things Di said to me when I arrived in the department, amongst lots of good advice, was go up to the university and listen to these lectures from Andrew Reid, and then you'll learn some stuff. And I must say, they were really inspiring, and today we've heard that again. And it was lovely to hear Andrew's support of clinical genetics, because we've heard some great examples and great speakers this morning, but clinical genetics is a specialty which is being undermined in this country at the moment by a number of senior people, and we need to do everything we can to protect it and see the value of the people working in that area and the need of the good that they can do for patients. So the other thing I discovered this morning was that Mike Parker's hair was very similar to mine at the similar age. So big 80s hair, that's what we want. They're my disclosures. And as Di said, I've been incredibly lucky to work with some fantastic people. What I'm going to talk about today really reflects a multidisciplinary approach across a number of different specialties, all coming together to work together, but particularly the work of my fellow John McDermott, who's here, who's really driven most of this work, but then people in health economics and implementation science. I'm not a computer whiz, but to do some of the work we need to do and to deliver it at scale, you need to understand how data moves around. And so actually quite a bit of my talk will focus on trying to make that understandable and realistic. When I started on the wards as a house officer years ago, one of the things that struck me was for so many patients, we were told to start them on this drug, warfarin. And the doctor said it's 10 milligrams, then 5 milligrams, then 5 milligrams. And then a few days later, you check their clotting level, their INR test. And some was up, and some were down, and some were in the middle. And it all struck me as completely crackers why some of the people were big, some of them were small, some of them were women, some were men, some had other medications, some had liver problems, but we're just giving the same dose to everybody. And it just didn't really sort of chime. And this understanding of why people don't respond to medicine or why they have side effects of medicine is something that I'm going to focus on today. But one of the most important things is not to think it's all about genetics. So, when you go to see your doctor or a health professional, the first thing you want them to do is to make the right diagnosis. We heard that this can be an odyssey for people with rare conditions, but actually that could be a diagnosis about the overall condition you're affected by or just about the particular symptom, and making sure you get that right. So if you've got shortness of breath, that could be because you've got heart failure, could be because you've got asthma, could be because you've got a chest infection. But the treatments are going to be completely different. And so if you don't get the diagnosis right, the drugs aren't going to work, are they? Increasingly, as people live longer, except for the last few years when they're not living quite as long, but generally people are living longer across the world, which is a good thing. But people are taking more medicines as they get older, and they're taking lots of medicines that interact, and sometimes they don't interact in quite the right way. Lots of people you might go home and you'll open your bathroom cupboard and you think, oh, I haven't finished those, or I haven't thrown them away, or I should have finished the course, as the doctor said. People don't adhere to their medicine. And for all sorts of reasons, sometimes because they don't feel very good on them, or sometimes they just forget. But drug adherence is a really important reason why people don't respond, especially to things like antihypertensives or those sorts of drugs. Last year, it was estimated that there were about 250 million drug prescription medication errors in the UK. It's enormous. So that could be the doctor's written it down in a way that it can't quite be read, or they've misspelt it, and so the wrong drug's been prescribed, or they've prescribed the wrong dose, or at the wrong time of day, or for the wrong length of course. So we need to get that better. When people come into you and say they come in and they've got a bag rattling with stuff from Holland and Barrett, that might be great, but it might interact with all of the stuff that you're wanting to prescribe them. So you need to understand broadly what they're on, not just their prescribed medication. And as I said, people have all sorts of comorbidities that might impact upon their medication. But what I'm going to concentrate today as it's a genetics meeting, and this is my world, is on the genetic predisposition to why we respond to medication in different ways. And so this isn't a new thing. This has been something that people have been thinking about for a long time. And a lovely example is from a geneticist, Arno Matulski, who recognized in the States, a lot of African-American soldiers were coming back from war with severe hemolytic anemia. And it was because of their reaction to their anti-malarial medication. And they had an X-linked condition called G6PD deficiency. And in genetics, we've known that some patients don't respond very well to medication. We know that people with a heart rhythm problem called long QT syndrome, or patients with a rare metabolic condition called porphyria, you've got to be very careful about which drugs you give to them. For example, a very rare condition called cocaine syndrome. If you give those children an antibiotic called metronidazole, they go straight into liver failure. If you give patients who have got Marfan syndrome an antibiotic called ciprofloxacin, they're much more likely to have an aortic dissection. So we know that there are specific examples that we need to enact in clinical practice. But what's happened over the last few years is been a much greater understanding how drugs are metabolized and the enzymes in the liver that control that particularly. And so there's this group of enzymes called the cytochrome P450 enzymes, which have really helped our understanding in why some people might respond to drugs or not. So as the focus was around 2004, I just wanted to bring us back to this Our Inheritance, Our Future document from the Department of Health. And within that, they flagged pharmacogenetics as an area where we could really make some progress. Because in truth, before that, we hadn't really, and I'll talk a little bit about some of the barriers to that. So at that time, a professor of pharmacogenetics, Munir Pir Mohammed in Liverpool, was appointed, and they funded 5 research projects, and I was involved in one of those called Target, which was to generate evidence to say that a particular genetic or biochemical test of a TPMT, which Andrew mentioned, should be employed before people started on a drug called azathioprine. And this was knowledge that had been around since the 1980s, but it hadn't been adopted into clinical practice because people said, well, the evidence isn't strong enough. So we thought that undertaking a randomized controlled trial would be a way of sort of shifting that clinical equipoise. So if you went to the literature and you looked at, let's say, the FDA guidance on different drugs, there's over 500 drugs and gene associations where there's some evidence to say, oh, maybe we should do something about that. But if you distill that down, there's an implementation consortium that has said, actually, the evidence is really strong for these 28. These are the ones you absolutely should be focusing on. So how are we doing? Well, in the UK, we're delivering testing for 4 out of those 28 at the moment. Okay, and I'll tell you a little bit about why that is and what we can do to shift some of that. So you could say, well, are we only doing that because that's America and, you know, things are a bit different in the UK? Well, this is data from the UK Biobank, so 500 million people. And if you look at the drugs that people who are part of the UK Biobank have taken, so they've taken very common drugs. Right up at the top, you'll see ibuprofen, which is a painkiller. About a third of the people who took part in Biobank have taken that drug, and about 15% of people have genetic data that would shift their prescription of that drug. If you look at the second drug on that list, simvastatin, about a quarter of people have taken simvastatin. About 20% of people have a genetic change in their data that says you should change the dose or think about how you're doing that. So the list goes down, and if you look across the whole of UK Biobank, over 99% of people carry at least one variant in a gene that's relevant to a commonly prescribed drug. So this is relevant to all of us. All of us should be having this information to guide safe prescription. And a quarter of people have at least 4 different genetic variants which are relevant to our drugs. Okay, so this is lots of people. So if you think then about the scale of what we could do with this information, about 1.25 billion prescriptions were prescribed last year in the NHS, costing about £11 billion. And you look at the areas, where was that money spent? So in endocrine disease, diabetes, obesity, cardiovascular disease, neurological disease, respiratory disease. I was fascinated to see that cancer drug spending only came 10th on that list, because my sense was that's all we read about in the newspapers. Everyone says there's too much cancer care. Well, there probably isn't if you look at across everything else. But some of the drugs, like atorvastatin, 65 million prescriptions every year. And we know that in 20% of people that carry a genetic change, that would change your prescription of that drug. So, this paper came out last year saying that rather than maybe thinking about doing one test for one gene, we should maybe take a slightly different approach and look at a panel of genetic variants. Now, this was a very contentious study for lots of reasons, methodological, statistical, etc. But it did have some practical messages. One, it was done in 7 countries across a very heterogeneous landscape of different clinical scenarios. And fundamentally, it showed that if you introduce genetic testing and use that information, you could reduce adverse drug reactions by about 1/3. Now, there's probably more work that needs to be done, but we're not focusing on trying to generate the evidence that pharmacogenetics is a good thing. We're really pushing to see how can it be delivered? How can you do it in clinical practice? So there are 3 potential models. A reactive model, where a person comes to clinic, you think you want to prescribe them a drug, you take a sample, send it to the lab, result comes back, and then you give a prescription. So that's the reactive model, and that's what we do at the minute. So for a small number of genes, this is what we do, and it's quite effective, it's quite straightforward. The result goes back to the clinician who wants that information, and it's just a one-off piece of information. You could use an approach called reactive with planned reuse. So a person comes in, you want to prescribe them a drug, and instead of just doing one test on one gene for the drug you want to prescribe them, you do a test which captures more information so that you've got that information for the drug you want to prescribe them at that time point, but you've got that information to use in the future when they come back and you might want to prescribe them something different. And that's what we'll talk about in a little bit more detail. And the golden uplands are preemptive, and that's what we want to get to, where essentially everybody across the whole population has this information, it's available to them, they either carry it around with them or it's in their electronic health records, and that information can be used whenever you need it. So that's preemptive testing. One slight different scenario, and this is very much about the context and where you use this information, is point of care testing. And I'll illustrate that with an example, which is a reactive test. You want that information straight away. It's just that rather than waiting a few days for the lab to do it, you might want that result in minutes or hours. And so how do you generate that information? So if you have a child and they present with a common autosomal recessive condition like cystic fibrosis, you know at some point in their life that child is going to need antibiotic treatment for their chest infections. And that antibiotic treatment almost certainly will involve a drug called an aminoglycoside, part of that group, so like gentamicin. So you can take a sample from that child, send it to the lab, and you can work out if they carry a genetic change that means they're susceptible to one of the side effects of gentamicin, which is that they get hearing loss. So 1 in 500 people carry a change in their mitochondrial genome that means that they're at high risk of developing hearing loss. So if you've got time to do that and the result comes back, a few months later when that child needs antibiotics, you say, oh, you've got a change in your gene, we won't give you gentamicin, we'll give you an alternative. You could say, well, let's give an alternative to everybody. But actually, gentamicicin's a really good drug. And if you gave an alternative, you might end up with antibiotic resistance to that. So sticking with a good, narrow spectrum drug is a good idea. Now, if you take a different scenario, about 10% of all babies, when they're born, need to go to special care baby unit or neonatal intensive care unit, either for some checks or because they're severely concerned that that child is unwell. And either those children will have a high risk of infection or they already will have an infection. And the standard approach to those children is that you have to give them antibiotics within an hour, okay, within an hour of their admission. So you give them gentamicin and penicillin. And so there's about 100,000 babies every year that are admitted to the neonatal unit. If 1 in 500 carry this genetic change, 200 of those babies are at risk of going permanently deaf. So can you do something about this? So this information, this genetic information, the original study that identified the gene change came out in 1993. But no one was using this information because you couldn't generate it quickly enough. So we worked with a small local company called Gene Drive to generate a rapid test. We used a LAMP technology rather than PCR because that was quicker, and there'd been some experience of using that during COVID testing. It's a standard what's called melt curve analysis to separate out here's the variant, here's not the variant. You get a fluorescent readout, and within 26 minutes, you can get a result. So that looks great. You can do it in the laboratory, and we were able to show that technology worked. Could we do this at 3 o'clock in the morning on a busy neonatal unit where the baby's ill, the nurses are rushing around trying to do everything, trying to remember everything? Can you do this test? Can you use that information? So we designed a study called PALO, which really investigated that in some detail. So what we wanted to do was to introduce this testing just completely as standard. And one of the things that was a challenge was the fact that this was the first time, as far as we were aware, that genetic testing had been taken without explicit informed consent. Because it was an acute situation. The mother had just given birth. The baby may have been rushed up to the special care baby unit. You needed to do the test straight away. Of course, you didn't have permission to do any test you wanted, just for the specific variant. And that's something that Annika helped us with, and others have been very interested in that different scenario of presumed consent. So we were able to show that introducing that testing in 750 babies consecutively coming through, we only missed 10 babies, and that was remarkable considering how busy it is and just introducing it into routine clinical care. We identified the variant in 3 of those. We gave them an alternative antibiotic. And importantly, we showed that introducing this testing didn't delay the time it took for the babies to get their antibiotics. So that has now moved to a nice early value assessment. They have approved that. We're waiting the outcome of a formal announcement will happen the first week in November around a national pilot rollout across the UK, and we're very keen to try and get this adopted into routine clinical practice. It's also helped spur on our thinking about, well, where else can you use this point of care genetic testing? What other clinical scenarios? So one area we're working on at the moment is in stroke, for patients who have had a stroke or a minor stroke called a TIA, where they're put on medication called clopidogrel to try and stop a second stroke. 30% of white European people don't respond to that drug. 60% of South Asians don't respond to that drug. So we need to know that as soon as we can to get them onto the right drug to prevent a stroke. And the amounts of money you can save, but also the benefits to the individual of avoiding a second stroke are remarkable, hundreds of millions of pounds. So this is our current practice, where you do a test, you wait some time, you get your results, you make a prescription. Can we shift to this planned reuse or preemptive testing? So we've been working in this area for a little bit, and we got some funding last year from NHS England, from their transformational Network of Excellence programme, to look at this in a little bit more detail. So when you start something, it all seems like a good idea to go and find out what other people have been doing around the place and learn from them and what their experience is. And so, as you can imagine, most pharmacogenetic programs, there's a really good one in the Netherlands, but most programs that are in the literature are from the States. And they do some really good work. But one of the challenges is that if you're in a hospital in the States, you're generally interested in making sure that your hospital is the best, and you don't care about all the other hospitals. And so you're not interested in information moving around and being shared. Whereas if you're in the NHS, you want the GP to know, you want the hospital to know. If you're at another hospital down the road, you want that hospital to know. And so that was part of our thinking about how we needed to create something that was interoperable and that would work for everybody, not just if you went just to your one GP or to your one hospital. So we designed this study called Progress. It's based in primary care, and I'll talk a little bit about that, but that's mainly because 90% of all drug prescription happens through GP practices. And it's a program where we're looking at what's the right test that we should do in the laboratory, how do we move information from the laboratory into a doctor's or a pharmacist's medical record, and then how do we actually do it? And of course, this needs experts in the area. It needs health economists to work out, is this value for money? We need people to understand the pathways, the implementation scientists. And we've done lots of work with the public to try to understand what they want. And I'll talk a little bit about John's work in that area. And so I'm not going to talk about the testing in any detail, except to say that companies are investing in a big way in this space. The testing is becoming quicker, cheaper, more automated. There's more that you can do for less money, and that's a good thing. There are challenges around that. People are thinking, should you use whole genome sequencing? That might be something for the future, not probably something in the short term. But essentially, there are lots of ways you can generate pharmacogenetic information. So I'm not going to talk you through the different machines and the different ways of doing it. The more complicated bits are the data. How do you move that information around, and how do you make sure you give people information that they can act upon? And then what do people, as in patients, the public, and health professionals want? So let's start with the data. If you do a genetic test, and a number of you as clinical geneticists will be familiar with this sort of scenario, you get a result back from the laboratory and they give you this sort of nomenclature, this sort of information. And for someone like myself, I think, oh, that's quite interesting. They've got this variant, that nucleotide, that variant in that particular protein, and they've got this particular genotype. You give that information to most clinicians, most health professionals, and their eyes will start to spin and they'll switch off. And they're not interested, they just think it's just you being you. And so you've got to move that information into a way that people can do something with it. And so you can convert that into this star allele system, which is a bit peculiar to pharmacogenetics and a bit irritating. And you don't need to know the details of that, but essentially you all know that everyone's got 2 copies of every gene or every allele, and so you can create a diplotype. But if you say this person is CYP2C19 star 3 star 5, still most people have got no idea. So you can move that information as to predicting what does that do to the enzyme or the protein. And in this particular case, it means that person's a poor metabolizer. So it tells you that their enzyme's not working as well as it should do. Still not great, because most doctors, you say, CYP2C19, poor metabolizer, they're saying, well, what do I do with that information? What does that mean? So what we've done, lots of co-design work, asking people what they want, and what they want is guidance. They want to be told, do I need to give an alternative drug? Do I need to give a different dose? What do I need to be thinking? What do I need to do to make this safe? And so we've designed, and it's very much a royal we, designed a system that allows you to convert that information into guidance, and you make sure it's linked into international guidelines and that they're constantly updated in real time, okay? So you can link into this CPIC guidance. So how do we make that work in practice? So you can think about at your far end, your laboratory, and there are lots of laboratories all generating genetic information. And I'm not going to say you have to use that machine or that test, as long as the information comes out in a particular format. And then you can move that information into what we call a clinical data repository, where you standardize it all and you make sure that it all adheres to certain internationally approved guidance. But then, that's only one thing. You've moved it into a particular place where it's sort of helpful, but how do you link that to all of the different health records? So you can imagine that if you go to one hospital or one GP practice, the electronic record system they have is different, and how they get alerts within those systems, they use different systems as well. So you can't say, oh, because your GP uses that system, that's fine, we can work with you, but we forget everyone else. You've got to create a system that works with all of the systems, because you're never going to have, as we've seen from previous experience in the NHS, a system where it's just one unified system across the whole place. It's too expensive, you've got legacy issues, and so you've got to work with what you've got. So how do you move that information into these different places? And so there are different ways of doing that. We've got phase 1 and phase 2, and I'll talk you through those. So phase 1 is The result comes back, the doctor gets an alert, they log on to a web portal, they put in the patient's information and their NHS number, and up comes this recommendation. You wanted to give them citalopram. It's a traffic light system. This is red, it says beware. It says consider an alternative. The drug's not predominantly metabolized by CYP2C19. Okay, so it makes you think that you can give them something else. If that patient comes back a few weeks later and you want to give them a statin, you've got that information there, you can interrogate it, you can see, oh, the statin's fine, I can give them a statin, that's okay. So that's okay, but actually it's problematic. Because if you're a GP and you're really busy and you get an alert that results come in, you don't want to log on to another system. You don't need to remember the password for it. You don't need your attention distracted. What you want is the information embedded in that patient's own record that you're already working in. So if you're thinking, oh, I want to give this patient citalopram, you start to type it in, and that an alert immediately comes up on your screen and says, oh, beware. Now, in theory, we're getting to the point that if the patient types in citalopram and it's fine, then nothing will come up. At the moment, we've got a little alert coming up saying, yep, they've had the test and it's okay. But actually, we don't want alert fatigue. We only want GPs to see things that they're going to act upon. Same with pharmacists. So excitingly, just in this past week, we've expanded the study from the Northwest, which I'll tell you about, and we've had our first practice open up in Hampshire, where this new process works, where they get the result straight into the patient's record only at the point when they're wanting to prescribe the drug. So they're not constantly being bombarded with different information. And if you can do this for pharmacogenetics, you can do it for polygenic risk scores. You can do it for other genetic information where you can flag up bits of information that are tailored to that individual. So I've talked about the data. We're working our way to a solution that is scalable. Of course, there are still always challenges working with all the different providers, but we've made good progress there. So how do you deliver the service? So the service, you go out and you ask people what they think and what they want. And so John, as part of his PhD, undertook this very large-scale program of work where he undertook a discrete choice experiment of 2,500 members of the general public, broad range, different ages, different backgrounds in all sorts of ways, and asked them questions about what they thought about pharmacogenetics, and I'll tell you about that. And then we asked 300 health professionals, GPs and pharmacists particularly. So when we asked the public, we sort of set them a case scenario. Well, this is a starting point. This is what we normally do. We take a blood sample from you, we get a result back, a few weeks later, and you don't have any access to that information and you can't reuse it. So if you say to people, actually, how important to you is it that you could have access to your own information, or instead of a blood sample, we could do a cheek swab. If you add all of those things, eventually you can get to a scenario where people said, yeah, I'll have that. You get to nearly 100% of people saying, I'd be interested in that test. If you could do a cheek swab, if I could have access to my own data on my phone or my app, that's really increasingly important to people, that they don't want data just to be on a computer that the doctor can see. They want to see it themselves. And COVID, I think, has changed that. And can that information be used by my GP and my hospital and by various people? So when we asked doctors what the most important thing to them and pharmacists what they wanted the results straight into their electronic record. They didn't want to be searching around for it. And also, they only wanted us to test variants that they knew what they could do with that information, that they could action. They didn't want to be pondering, like as a clinical geneticist, you get a variant and you think, I wonder what that means, I'm not sure. That's fine for some people in genetics around certain clinical scenarios, but when you're prescribing a drug, that's not sensible. So, the study that we're running at the moment, the progress study, it's triggered by a person coming to one of a number of different GP practices. We've got about 14 open across the Northwest at the moment. They're either being started on an antidepressant, a statin, a proton pump inhibitor like omeprazole, or on an opiate. We're doing it under research ethics, which is a little bit problematic because we need to fill out more paperwork and do more things, which sort of breaks the normal clinical flow. but that's fine. The result comes back in about a week, and then people are given that information. And so far, quite an even mix between males and females. Quite interesting, quite a lot of young people are taking part in the study, and about 3/4 of the individuals are white, British European, but quite a mix of people from different ethnic groups. And one of the things that we know, I mentioned the example around clopidogrel before, where there are these differences dependent on how likely you are to have a genetic change in a certain gene dependent on your ethnic background. We're not seeing that this is a barrier when you offer it to people. People do want this information, irrespective of socioeconomic group and ethnicity. So just to very briefly show you, of the 300 people we've recruited so far, so this is an ongoing piece of work, about 28% we would give a different dose of the drug based on that. So that's a large number of people. And in the vast majority of people, we're seeing that the doctor and the pharmacist are adhering to the guidance. And the reasons why people might not adhere to the guidance that we're giving is because they say, oh, well, actually, I feel a bit better now and I might not need that medication. Or actually, I'm going on holiday, so I don't want to start it, or I'm doing my exam. So there are a myriad of reasons why the advice isn't given, but often it's about the fact that the patient doesn't want to start the medication. And so the two big drivers are statins and SSRI, so sertraline, but we're starting to see an increase in, because we only introduced this later, in opiates. And the next stage of the study is to roll it out across the whole country. So we've just started that in Hampshire. We're moving to Cambridgeshire, to the West Midlands very soon. We've moved to an e-consent processing process and linking in with different clinical pathways. So my final couple of slides are just to say, I talked about those golden uplands. How do we reach a situation where everybody has pharmacogenetic testing, and we've got that information in our records just when we need it? So how do you roll it out to 60 million people? Well, that's challenging, but we do have some experience of that. Okay, the costs are going to be large. You need a good infrastructure that's very much automated, just getting the samples through, and you need people to want it. But one piece of work that John's been looking at, which I think helps to inform this, you need to understand what are the drugs that people are using. So this is a group of patients that came into our acute hospital unit, and you see lots of people are on proton pump inhibitors, lots of people on statins, on opioids, on clopidogrel. So these are all drugs that I've already touched on that are relevant to pharmacogenetics. And if you look at the age when suddenly people are on quite a lot of these medications, there's a sort of inflection point at about the age of 50. And so if you're thinking about the COVID scenario, where we started offering vaccination to people at an older age, and then people who were more vulnerable because they were coming into hospital, you could see a scenario for pharmacogenetics rolling it out where you start with older people because they're more likely to be on more drugs, and then reduce it to a point where eventually you've got the whole population covered. So to finish off, the use of pharmacogenetics is clearly increasing. We're at a point where I think the technology, the informatics, the will is starting to come together to really make this a reality. We're moving from this scenario of just a single gene, single drug, to thinking about panels and maybe something more expanded than that. I haven't touched on polygenic risk scores, but they will be important in how people respond to medication. So creating algorithms, so it's not just thinking about one gene, but you build up an algorithm so that for every patient you take into account their co-medication, lots of genetic factors, their liver function, their age, etc. And that gives you the information that helps to guide prescription. And moving to that preemptive model so that we can make this a reality and effective for everybody. Thank you very much.